morning, everyone. My name is Jaysson Brooks, and I am the chair of the SRS podcast committee. And I'm really excited to be here with my colleague, Dr. Carol Weiss, who, along with her colleagues, won the Hibbs Award for the best paper in basic science and translational research. So we're here just to celebrate your award.
Thank you.
And also to talk more about not just the project, but the author. And so just congratulations, Dr. Weiss.
Thank you so much. It's very kind of you.
So a little bit about your background. I Googled your extensive history, and it sounds like you're a native Texan.
Very native.
Okay. And so Dr. Weiss, from what I could read online, she went to college at Texas A&M, studied in chemistry.
Yes.
And then she went on to do her doctorate at UT Southwestern, just right down the street here. And then you did your postdoctoral work with two people who I know are probably famous, but I hadn't heard of. That's James Lupsky at Baylor College of Medicine in Houston, and then Michael Lovett at UT Southwestern. And also Dr. Weiss is the founding member of the International Consortium for Spinal Genetics, Development, and Disease.
Right.
So we're going to kind of get into all that. So Dr. Weiss, after going through your background, I guess my most basic question for you is, how did you get into spinal genetics? It doesn't seem like something that you would kind of like look through the coursework in a normal university and say, this is what I want to do.
Right. That's a great question. So I got into spine genetics, first of all, by getting into human genetics. So you mentioned my first postdoctoral fellowship. That was with Jim Lupsky at Baylor. So when I finished my PhD, I said, I really want to get into human genetics and the Human Genome Project, and we were going to be located in Houston, and so I was very fortunate to pair up with Dr. Lupsky. Jim Lupsky had just discovered the genetic basis of Charcot-Marie tooth disease, of the most predominant form of it that you're well familiar with, I'm sure, the 17p duplication. And so I joined his lab and learned so much. He's an incredible teacher, and Baylor is a great center. And then we relocated to Dallas, and I continued with a second fellowship in human genetics. And it was in that second fellowship that we mapped a gene in the genome that we suspected was connected to hereditary multiple exostoses.
Okay.
And so we were advised that we should come talk to the people at Scottish Rite Hospital who see this, this rare disease not infrequently.
Yeah.
And so that began a conversation. And when I finished that fellowship, we decided that it would be, a win-win to establish a molecular genetics program here. So how did I get into spine? Part of establishing that program was meeting with orthopedic surgeons in Dr. Herring's office at that time, everybody in a big circle at the table. And I said, what is a clinical problem for you that we might be able to solve using genetics? And scoliosis was pretty much what was said in unison. Okay. And so that's how I got started in spine genetics. It was, I have learned these tools, and my goal and my job is to apply those to something that is a clinical puzzle to you. And we went from there.
Yeah. And I think one of the most fascinating things is that, it's 2022, and we still use the word idiopathic to describe one of the most common types of scoliosis that we treat. And so your goal was to take that word away, I assume.
Yes, that was my goal. Yes, still working on that.
Yeah, perfect. So, I had to jot down some notes about your project. So your project was titled Variants in Collagen Homeostasis Genes Are Associated with Adolescent Idiopathic Scoliosis. And so specifically, you identified genes that are producing components of the extracellular matrix in cells throughout the body. And you found that some of those genes are associated with adolescent idiopathic scoliosis. I guess my first question for you is, why did you decide to start looking in the extracellular matrix versus all the other parts of the cell that I may have forgotten since medical school?
Right. Yeah. It's another good question. So sort of picking up where I left off, when we started our work in idiopathic scoliosis, it was a clean slate. There were no discoveries. And so we've spent many years working with our wonderful patients and clinical staff to work on discovering genes. And so we have a sort of a bucket of genes, I tell people, that we've discovered over the years. And when you apply start putting the pieces of the puzzle together, you see that many of those genes are involved in forming the extracellular matrix. And so we said, okay, we think we see a pattern here. And so our next step was to say, okay, instead of using just looking for genes at large, we're going to apply a hypothesis. And the hypothesis is there are more genes involved in the extracellular matrix waiting to be discovered. And so we look specifically at those genes based on prior evidence. That's the answer to your question.
Okay, now I know a lot of our listeners are going to be surgeons and scientists, but we do actually have a lot of lay people, patients who hear this podcast. So if you can just, in your like scientific way, dull down, what is the extracellular matrix? What is that?
Right, right. So, you know, if you think of our bodies and you think of, you know, your skin and your bones and your muscles, well, those are made up of cells, you know, and the basic component of those tissues is cells. Well, what holds the cells together? It's a matrix. And so it's called extracellular because it's outside the cell, and it's a matrix that's holding those cells together. But what we've learned is that it's doing more than holding together. It's sort of sending signals into cells, and it's receiving signals outside of the cell. So it's a major component of the body.
Okay. Thank you. In your paper, you took genetic samples from thousands of children with AIS, adolescent idiopathic scoliosis, as well as lots of kids who we call normal controls, those who don't have scoliosis. And these kids are from the US, Sweden, Denmark, Japan, Hong Kong. How did you kind of bring together this cohort, first off, of researchers who were able to get kids from all across the world to submit samples? Like, this seems like a Herculean effort. How did this process start?
This is one of the joys of science because, you know, there are strong connections throughout the world. So this started with our consortiums. 10 years ago, more than 10 years ago, I was at a meeting of a foundation called Cottrell Foundation, who's been very supportive of research. And there were other people in the room, and someone said, you know, we need to find ways that we can collaborate. And so we formed this consortium, ICSGDD. I'll use the acronym because it's a lot easier than saying the whole thing. But these are interested people who, you know, they're either clinicians or researchers like me who are interested in different aspects of the spine and how it develops and, you know, problems that arise with spine development. And so it was through that group that we were able to do this. And so the way we work together is if any of us has an initial discovery, we reach out to the others and say, I'm seeing this. Could you look in your data and see if your data validates what we're seeing? And that way, you know, strengthen numbers.
Yeah, that's really interesting. So specifically, you detected a couple variants associated with genes that are produced by the collagen, genes related to collagen type 11A1. And I'm not going to actually name those genes, but at least it seems like this is associated with the parts of the body that form the end plates of the vertebra, as well as kind of the nucleus pulposus, so the center of our kind of intervertebral disc. All structures that are involved with what we think is likely related to idiopathic scoliosis. By identifying these genes related to collagen type 11A, are we now able to do some sort of gene therapy now to basically cure scoliosis? Like, are we very close to that, or is this very much kind of the foundational work to looking deeper into it?
Right. This is a good question. This is foundational work that I would say, however, is opening a window into the possibilities of therapy. And so with this discovery, first of all, we're working on modeling that in other systems, animal models. And so that's, once we have that established, then you can start thinking about how you might correct, you know, because that you go in stages before you go directly to therapies in human patients. But we're very excited about it because it's putting those pieces of the puzzle together, as I said. And the other part that was not part of the presentation is that we think we have some evidence that estrogen is a component of this puzzle. And so why this happens in adolescence, we think we're beginning to have some understanding of that.
Hence the higher incidence of idiopathic scoliosis in females.
Right, right.
But kind of downstream, we do see it in boys. So does that mean that boys might have some sort of in those boys that develop scoliosis, there's some estrogen link also?
We don't know,
Yeah.
but we're not thinking in those terms. One thing to be very clear about is that this is a heterogeneous disease, meaning many different causes. Some patients will have a combination of factors that's not exactly the same as other patients. And so we think in boys it could be a different set of factors that's causal, and we're working on that too.
Okay, perfect. So really exciting news. Hopefully Dr. Weiss's work will put me out of business so that I won't be able to operate on kids with scoliosis anymore. But kind of to end our conversation, we always have a lot of conversations with surgeons about what does work-life balance look like as they're trying to balance their clinical career, their research, their family life. For a scientist like you who specializes in spinal genetics, what does work-life balance look for you? You know, when you're not doing research, where do you find time to be a spouse, a mother? Like, how do you find that balance, or do you feel like it's easier on the research side?
I don't have a way of comparing to the clinical side. I think, first of all, I've been very fortunate to have just a very patient, wonderful family. You know, my husband, my children have always told me to go for it, and I had doubts. And, all people have doubts, and I had doubts, and I always had strong support at home. And I'm so thankful for that. I do, try very hard to just prioritize. If today the priority is not coming in here, then I will find a way to not come in here and do what needs to be done. So, I've just been fortunate to work in an environment that allows that to happen.
Awesome. Perfect. Well, Dr. Weiss, congratulations again on winning the Hibbs Award. And you all stay tuned for our future podcast announcing the other award winners from our annual meeting this past month in Stockholm, Sweden.
Thank you.
My name is Masood Shafafy. I'm a spinal surgeon from Nottingham, UK, and it is my pleasure an honor to host this particular podcast. And it is my pleasure to host this with Dr. Lærke Ragborg from Denmark. Dr. Ragborg, can you introduce yourself first, and then we go on to introduce the rest of the interview?
Yes, of course, and thank you for having me today. My name is Lærke. I'm a doctor and PhD fellow at the spine unit Rigshospitalet in Copenhagen, and currently spending my time doing my PhD on adult spinal deformities and long-term follow-up in adolescent idiopathic scoliosis.
Fantastic. For the viewers and listeners to the podcast, they are well aware that you were co-authoring or working with a group of people with this particular project, which was presented in the 57th annual SRS meeting, and you were awarded with the Best Clinical Paper Award, Russell Hibbs Award, which is quite distinguished for this type of work. It is, as you mentioned, is a long-term follow-up, 40 years of health-related quality of life in patients with untreated adolescent idiopathic scoliosis, which is a fantastic paper. And I really enjoyed listening to you in Stockholm when you presented it. Could you just go over this particular piece of research for us, please?
Of course. So we've conducted this 40-year follow-up study, actually in all adolescent idiopathic scoliosis patients treated at our facilities back in the 70s and 80s. Both patients undergoing solely observation, but also brace treatment and surgically treated patients. And what we wanted to see is how are these patients doing when they grow up and when they become adults, and especially at a time where we know that adult spinal deformities or pain in these patients starts to become more prevalent. So we wanted to see if these patients are doing as well as the background population, and if not, if we can find some predictors that tells us what patients are at risk of lower lower quality of life. And we also did the part on curve progression over time, which obviously has been very interesting as well. As we all know, it's generally accepted that the larger curves could continue to progress after skeletal maturity, but we don't really know what happens to the smaller curves. So this study has been helping out highlighting that point of it as well.
How did you come across this research? Because I've just gone through some of your CV, and you were involved with another similar paper with Sherman, which nearly, was nominated, but unfortunately didn't win in Montreal in 2019, which was 39-year follow-up for Sherman kyphosis, untreated Sherman kyphosis. How did you come about this piece of research, and what was your role in this?
So I started out as a medical student during my second year to look into this matter. So I did a clinical rotation in the Department of Orthopedic Surgery in Rigshospitalet, and quite quickly got interested in spinal surgery from that. And when I had to start my bachelor's thesis, I went and knocked on Professor Benny Dahl's office and asked if he could help me out with the project. And he had these index cards or cards with the patient's social security numbers, which is something that everybody in Denmark has, and a diagnosis, nothing else but that. So we went to the local archives where they stored all of the old patient files, and we started to go through all of them. And I ended up starting out this project during my bachelor's, and then continuing during my master thesis as well. And now I've taken it into my PhD as well. So I've been working on it since 2015, alongside Professor Benny Dahl and the other authors.
Your work on this particular paper is in almost two sections or two wings. One of them is the progression, and one of them is the health-related quality of life in these patients. And working on the progression, as you know, most current up to now literature says that for milder curves, the rate of progression is very, very small and almost negligent. And up to now, we have reassured patients that if their curves is below 50, then the rate is very, very small and negligible. And how do you sort of explain the difference in findings between your paper and the current established literature?
I think it's difficult to come with one specific answer. Obviously, we have the radiographs from the last time they were seen in childhood, and then we have the follow-up radiographs 40 years later. And whenever that curve progression happens, we don't know. So if it's closely related to when they're last seen in childhood, or if it's something that comes with the degenerative changes with age, it's not something that we can point out at this time. I think it's relevant to conduct more studies where you follow them, maybe not every year, but with with a certain amount of time in between to see if we can figure out when this progression does happen.
Well, you touched upon my next question, actually, because I was going to ask the time difference between the last X-ray and last follow-up to the time when you pick these patients up on average 40 years later. The time difference, was there a huge difference between different patients?
No, so they were all seen within the same 10-year time frame, and we had like an average of 40 years follow-up. So, and obviously some of the patients were seen throughout that, like between the last visit in childhood and at follow-up. Some of them ended up continuing and having surgery, but the majority of them has not been seen anywhere for the 40 years.
Okay.
Yeah.
And let me ask you a tricky question. Did you manage to compare the group from the last follow-up before the study follow-up, whether they were compared in terms of skeletal and general maturity at the time when they were left from the follow-up until they were picked up?
So what we have is the radiographic descriptions from the last time they were seen. So they all had, as I remember, they all had wrist X-rays to confirm that they were skeletally mature. And the majority of the patients were followed for a period of time after they were skeletally matured. So we believe that at the time they were finished being seen, at the time they were actually skeletally matured, but it's only from patient files and descriptions from radiographers or radiographs, and from the treating surgeon that we have this information.
And is it fair to conclude that the gist of your paper is to recommend, regardless of the severity of the curve, even the milder curves from 30 to 50, you still recommend a type of follow-up and not being discharged completely?
I think it's difficult to conclude anything from one paper. I think it raises more questions, and I think we need to look a lot further into this before we can conclude anything. I think that we need to find some predictors that points in the direction of who is progressing over time. Right now, we don't know who's progressing and who won't. But with this particular study, we can't answer that question either. We've tried to do some extra analysis, or like some post-hoc analysis, to try and find predictors for a curve progression. But because the material is still relatively small, with 91 patients, it's difficult to examine all the different possible predictors. So I think more studies, which is similar to this study, should be conducted in order to get a little bit closer to finding an answer.
Oh, fantastic. Given the fact that you're the presenting author and an author for these two landmark papers, obviously the AIS hasn't been published yet, but you published the 39-year follow-up of Sherman. Mm-hmm. And the drop in health-related quality of life of those affected. What is your personal view about which one is the worst to have, AIS or Sherman, in terms of inferior level of health-related quality of life?
Well, so the Sherman patients actually, even though they did worse than the background population, they did better than the AIS patients. It would be interesting now to do the same sort of calculations on these patients, because we've got a lot more information with the AIS patients. We've also been looking into the rate of incapacity to work, and where We didn't do that with the Scheuermann patients. So I think it's not completely comparable, but if you're looking solely on the SRS scores, the AIS patients are doing worse than the Scheuermann patients overall.
Oh, all right. Thank you very much. With obviously you're starting your career in surgery or specialist surgery. What made you to choose this field in medicine?
I think I always thought I wanted to do something along the lines of orthopedic surgery or sports medicine. And as I said, my first meeting with surgery in general was as a spinal surgery. And I was really intrigued about the complexity and the skills that was required from the surgeon. I am probably a little bit competitive, and I like to be challenged. And I feel like that was a good match. It was not as straightforward as other things maybe could be. So I think that's what sort of awakened my interest in the beginning, and then being a part of the community and working alongside inspirational people has sort of taken me the last way there.
Oh, fantastic. Lastly, some political question. Given the gender proportionality or improportionality of presentation of male, female in surgical training and research setting, what do you think should be done at training level and as well as the professional body level to improve this balance?
I think it's really important to do something, and I think a lot of initiatives has already been done. If you're looking in general and also at a more, what we say, like in the societies or in the organization of the SRS, I think having women being visible, especially for the younger generation, is really important. It's important to have some role models and to see that it is possible to be a part of this regardless of your gender. I think there's also a natural transition happening everywhere at the moment. I mean, obviously, I can only speak for Denmark and from my experiences. But in general, the surgical fields are more and more women are going in that direction. And it is becoming more normal as well. And I don't think it should be forced, but it should be, especially for the new generation and the medical students, they need to have someone to look up to that they can identify themselves with. And so having females or well, not even, but just having someone that they can identify themselves with and be able to look up to and see that it is a possibility. I think that's the main thing that needs to be done. And obviously we're already moving in that direction. If we're solely looking at gender, with Serena Hugh now being the president, I think that's a major step. And it's it's really good to see that females are coming in that field as well.
Okay, thank you very much. Happy, perhaps good note. We would like to wrap up the session, and I really thank you for your time in answering the questions. Thank you very much, and well done with the fantastic paper that you presented, and keep up the good work. Thank you
very much.
The Scoliosis Research Society is a nonprofit professional organization made up of physicians and allied health personnel. Their primary focus is on providing continuing medical education for healthcare professionals and on funding and supporting research in spinal deformities. Please visit srs.org for further information.